Hello everybody and welcome to this webinar on Uterus ultrasound. We are very lucky to be joined today by Dr. and Professor Giovanni Niemi. Giovanni Niemi is a veterinarian who works for Bovine International, and he is an associate professor for bovine reproductive pathology at the veterinary faculty of the Catholic University of Valencia in Spain. Dr. Niemi has been working with ultrasonography in cattle since 1993. Dr. Niemi fields of interest are reproductive management, preventive medicine, and continuing education of farm and veterinary workers. In these areas of expertise, he has developed international experience, both as a consultant for large and very large dairy farms in Europe, South America, China, the Middle East, and as an instructor in more than 300 training courses around the world. He has numerous publications, many of them in peer-reviewed journals, and has presented approximately 280 lectures at national and international conferences. So with introduction done, I will hand over to Dr. Giovanni Niemi.
Okay, thank you very much, Natalia, for your kind introduction, and please permit me to thank IMV Imaging for this kind invitation. Today I will speak about uterus ultrasound evaluation. It is the first of a series of meetings that we will do about these topics. Well, if we want to discover by ultrasound if the uterus have an infection or an inflammation, an abscess, or other pathologies, first of all, we have to know very, very well the physiology of the uterus. Well, we have to start to the very basically steps. For example, in these pictures, you are looking at longitudinal section and transversal section of the uterus. About the different part of the uterus that we can scanner, you can see that from dorsal to ventrally, in the longitudinal section, we are looking the myometrium, the endometrium, the lumen of the uterus, the endometrium, the broad ligament, and then still we can see myometrium, endometrium, endometrium, and myometrium. Well, we have also looking at the vascular tonica and the lumen of the uterus. Well, you see that with the ultraportable unit, or with the portable unit, today we can see very, very well each part of the uterus, but not only in longitudinal section, but also in transversal section. In this transversal section of the uterus, we are looking at the myometrium and the endometrium. And also in the middle, we are looking at the specular reflection. This means that we are in presence of a few quantity of fluid inside to this uterus section. Well, about the technique, normally when I do an ultrasound evaluation of the uterus, I use a transversal section and longitudinal section. When I speak of a transversal section, I'm putting my probe perpendicularly to the bigger axis of the uterus horn, as you can see here in these two pictures. And this is what I do. You see that the movement, the only secret when I speak of ultrasound evaluation, the only secret that I suggest to my students or to the colleagues that I like to share is that there are no secrets. You have only to move the probe very, very slowly, and you have to maintain a perfect control with your hand of the probe. Here is a movie that we are doing with a portable unit of transversal section of the uterus very close to the body of the uterus, immediately after the separation of the two uterus horn. I'm looking at a uterus in probably of a cow that is very close to the end of metaestrus, first day of the estrus. But for to tell that is for sure this, we have to evaluate the follicular map. Well, another technique that you have to use is the longitudinal section of the uterus. In the longitudinal section of the uterus, you have to put your probe parallel to the bigger axis of the uterus horns. And here is the techniques. You see that you have to manage the probe with a perfect control. So normally I use the probe in the palm of my hand, and I use the index finger like a direction to put the probe where I want. Well, here is the movies, and you can see that it's possible to see also with a probe of 8, 10, 11 centimeters to see everything without any problems. Well, I was telling that if we want to check the uterus pathologies, first of all, we have to know very, very well the physiology of the uterus. I believe that to be able to recognize the different stages of the ovarian cycle is fundamental. We know that the ovarian cycle is divided in two phases, luteal phases and the follicular phases. The luteal phase is the longer phase and is formed by the metaestrus, the metaestrus length is 4 or 5 days, and the diestrus, that is normally between 9 and 11 days, and is the longer part of the estrus cycle. Well, the main hormones, steroid hormones, during the luteal phase is the progesterone, while the main hormones during the follicular phase, it is the estrogens. Well, I believe that it's extremely important that we know this point. Why? Because with the follicular map, I can predict if I am in a metaestrus, in early diestrus, in later diestrus, in proestrus or estrus. But there are some particular situations, like, for example, the follicular maps of the two follicular wave counts at day 14, so at the end of the diestrus, and at day 18, so in the middle of the proestrus, where the follicular map is similar. So we have normally two dominant follicles, one in regression, one is active, and the corpus luteum. At day 14, we have the dominant follicle that is bigger, is the atretic first dominant follicles, while at day 18, the bigger dominant follicle is the second dominant follicles. Well, can we distinguish between the dominant follicles by ultrasound? No. Also working with the Doppler. But what we can analyze is the different hormonal profiles in the two different windows. At day 14, we are at the end of the diestrus, so the progesterone is the main hormones. While at day 18, we have the main hormones, steroid hormones, are the estrogens. And the estrogens and the progesterone determines a totally different stratigraphy, ultrasound stratigraphy of the uterus, because change the thickness of the endometrium, the shape of the lumen of the uterus, the quantity of fluid in the lumen, change also the vascular tonica, change the echogenicity. So if I am able to distinguish these things by ultrasound, I can define if I am at day 14 or day 18. So the ultrasonography of the uterus is not important only to define the pathologies, but above all, also to define in which particularly part of the luteal phase or of the follicular phase we are working. Well, I start from the luteal phase, from the metaestrus, that is the first part of the luteal phase. During the luteal phase, improve the level of the progesterone and decrease drastically the level of the estrogens. But we have to remember that during the first 24-36 hours of the metaestrus, the level of the estrogens is still a little bit higher. So this means that the characteristics of the uterus during the first 24-36 hours of the metaestrus are very close to the characteristics of the uterus during the last part of the estrus cycle, so during the proestrus estrus. This means that we have contraction of the myometrium, a thicker vascular tonica, a thicker endometrium, and we have fluid inside to the uterus. In particular, the shape of the lumen of the uterus, the star image or a Christmas tree image. Remember also that there is a difference, echogenicity between myometrium and endometrium, because the myometrium contracted improve the echodensity, so reflect a lot to the ultrasound, appearing echogenic, while the endometrium is thicker because we have a vasodilatation. So the blood vessel improved a quart of blood, and the blood is a fluid. So the fluid absorbs a lot the ultrasound. For this reason, the thicker endometrium will appear hypoechogenic. As you can see in these pictures, in these movies, the follicles during metaestrus are very small. So normally it's just started the first follicular waves. We have a recruitment of follicles around 3 millimeters. And normally during the first day after the ovulation, we have follicles between 3 and 4 millimeters. And in these pictures of the left ovaries, you can see also the hemorrhagic body. The corpus luteum during metaestrus, it is not producing the quantity of progesterone. So in particular, 24, 48 hours after the ovulation, independent from the size of the corpus luteum, that may be between 10 and until 12, 13 millimeters in some rare cases, the progesterone production can be around 0.2, 0.3 nanogram per milliliters. But attention, the size, in this case, it is not correlated with the production of the progesterone. This, we speak of this corpus luteum high hemorrhagic body because after the collapse of the graft follicle, there is a microhemorrhagia inside to the graft follicle, and thanks to the LH level, the LH permit the transformation of the granulosa cell and theca cell in a bigger and smaller luteal cell. So is a corpus luteum that is growing. Well, 96 hours at the end, after the ovulation, at the end of the metaestrus, we have a dominant follicle. Well, the dominant follicle is around 8 millimeters. So 50% of the deviation is around day 4, and the other 50% between day 5th and 6th. Well, the minimum size for the deviation in the rectal is 8 millimeters. So this means that 8 millimeters is the minimum size of a dominant follicle who permit me to produce an ovulation, because we have enough number of LH receptors. So from this moment, have a sense to work with generate and relatively also with the prostaglandin. So the problem with the prostaglandin is not relative to the dominant follicle, but to the maturity of the corpus luteum. In fact, working with the prostaglandin at day 4 until day 5, 6, the total luteal lysis is less than 20%, so between 20 and 25, 30%. We start with a 65% of total luteal lysis only after day 7 from the ovulation. So this means that the corpus luteum, independent from its size, it is not working, it is not answering very well to the prostaglandin until day 7 or day 8. Well, the characteristics of the uterus and end of metaestrus are totally different from the first days of the metaestrus, because the level of progesterone now is around 2.5 nanogram. The level of estrogens is very, very low. So this means that we have a myometrium that is relaxed, so it's not contracted, so it's thicker. The vascular tonic is reduced in size, and also it disappears totally the edema of the endometrium, and so the endometrium is reduced the thickness, and also is improved the echogenicity. And normally inside the uterus we have only a virtual space for the fluid. We have some specular reflection, but not too much, as we have instead during the first 2 days of the estrus cycle. Well, during the estrus, the level of the progesterone increased a lot. So improve the corpus luteum size, and the growth rate of the corpus luteum is very, very high during day 5 and day 10. Then is still growing, but very, very low. Well, the level of the progesterone between day 5 and day 10 grow a lot, because we pass from 2.5 nanogram until 4.5 until 5 nanogram. But the bigger improvement of the progesterone is between day 10 and day 14. Day 14, so we have, so at the end of the estrus, we have a level of progesterone that is close to 8 nanogram of progesterone. Well, the characteristic of the diestrus is that improve the progesterone level. So we see that there is a bigger corpus luteum, and the characteristics of the uterus are typically of the diestrus. So thickness of the myometrium, thickness of the endometrium is similar, like the echogenicity and the echogenicity. And if the cow is not dirty with an inflammation, for example, the space inside to the lumen is a virtual space. I want to tell one thing. Attention, it isn't true that the echogenicity of myometrium and endometrium is the same. It is the same working with the frequency that we are normally using in bovine reproduction. So working between 5 and 10 megahertz. To analyze this difference of echogenicity that is present, we have to improve the frequency of our probes to 15, 18, 20 megahertz. Now I am showing movies of a diestrus at 6 days. You see that we have a dominant follicle. We have seen the dominant follicle around 12 millimeters, and you can see that in this cross section of the uterus, that myometrium and endometrium have similar thickness and similar echogenicity. There is a virtual space of the lumen, and the vascular tonica is very thin. Day 8, the corpus luteum is bigger, the dominant follicle is 15, 16 millimeters. In this case, you see that we have a cavitary CL. Attention, the cavitary CL in the cattle represents 70% of the corpus luteum during the first 10 days of the cycle. And you see that the progesterone is dominant in this phase at this moment, and myometrium and endometrium have similar thickness and similar echogenicity. The estrus at day 8 is the best moment to work with prostaglandin, because we have totally lutealized with the prostaglandin in 70-75% until 90% of the cases. This means that the cows are coming in heat, and the day of the estrus, they have less than 0.7, 0.8 nanogram of progesterone per milliliters. But it's also day 8 the best moment to start off cinch, because we remember that if you want to work with off cinch, it's important to work with 7 days of cinch. It's important to work with 2 follicular waves cows with in presence of a corpus luteum, but with the dominant follicle active, better if it is 15, 16 millimeters. Well, it is also the best moment to start a pre-synchronization with pre-cinch of cinch or with double of cinch. But it's also a good moment to work with short cinch. This is true until day 10. At day 10, the dominant follicle is arrived to the maximum size, the dominant follicle of the first follicular waves. So we are speaking of follicles between 17, 18 until 20 millimeters. We have very big size of the corpus luteum, 18, 20, 22 millimeters. And thickness of endometrium and myometrium is the same. In this case, you have seen a very big cavitary CL with a big cavity. Well, you see that if a cow it isn't with an inflammation of the uterus, there is no space inside to the lumen, and it's a virtual space, and we have only poor specular reflection because the quantity of fluids is very, very thin, so it's a virtual space. Well, day 10 is already started the second follicular waves. So normally the second follicular waves in 3 follicular waves cows is started between day 8 and 9, and between 9 and 10 for 2 follicular waves. And 4 days after the recruitment, we have the deviation of the second dominant follicle. This means between day 12 and 13th in 3 follicular waves cows, and between 13th and 14th in 2 follicular waves cows. Well, This means that from day 14th, we have always two dominant follicles, one bigger, the dominant follicle of the first follicular waist, and one smaller, the dominant follicle of the second follicular waist. Well, the corpus luteum is at the maximum of its size. We have the maximum production of the progesterone, and so this means that we have the characteristics, typically the estrus characteristics of the uterus. So myometrium and endometrium, same thickness, same echogenicity, no space inside to the lumen of the uterus. Well, if there is any maternal reconnaissance of the gestation, what happens? Happens that we'll start a signal from the mom to the posterior pituitary. The posterior pituitary release oxytocin. The oxytocin determines activation of the receptor, endometrial receptor, for the production of the prostaglandin PGF2 alpha. The prostaglandin PGF2 alpha go outside of the uterus with the uterus vein, and the uterus vein is surrounded from different branches of the ovary arteries. Well, there is a passage of the transfer of the PGF2 alpha from the vein to the arteries, and this prostaglandin produce a vasoconstriction. So this means that the corpus luteum blood flow reduce, start a young degeneration of the bigger and smaller luteal cell. The corpus luteum start to produce other oxytocin, who determine another stimulation of prostaglandin PGF2 alpha production. So it's a mechanism of auto-amplification, it's a loop until that we arrive to the totally degeneration of the corpus luteum and disappear the progesterone production. So start the positive feedback of the estrogens on the hypothalamus. This is what happens during the follicular phase. The follicular phase is formed from the proestrus, that is around 4 days length, and the estrus. The estrus is 1 day in theory, because the true situation is that today in very high production cows, the length of the estrus day, is between 6 and 8, 10 hours, no more. Well, what happens during the follicular phase? Decrease the level of progesterone drastically and increase the estrogens. Well, what is interesting, there is one aspect that I want to share with you today, is that the functional degeneration of the corpus luteum is very, very fast. So during day 16, 17, so during the first 2 days of the proestrus, the level of the progesterone go down drastically. So from 8 nanogram at day 14, we are between 3-4 nanogram at day 16 and 1-2 nanogram or at day 17, less than 1 nanogram between day 18 and 19. But attention, the faster drop of the progesterone don't correspond to the same modification of the size of the corpus luteum. In fact, we have a delay of 60-72 hours. This means that, as you can see here, until day 18-19, we can find a corpus luteum that functionally it is not working because the level of the progesterone is less than 1 nanogram, but the size is still very, very big. Attention, in particular, in free follicular waist cows, where the drop of the progesterone is delayed of a couple of days, 3 days. This means that looking this cow in heat around day 22, 23, you can find still big CL also the day of the estrus. Well, what happens at the end of the proestrus? That the level of the estrogen is very, very high. We have 2 dominant follicles, one bigger, that is the second dominant follicle, the last dominant follicle in case of free follicular waist cows is the third one. And then we have a smaller, that is the dominant follicle of the first follicular waist, or first and second in free follicular waist cows. But as you can see in this picture, there is contraction of the myometrium that will be thin and echogenic. There is thicker endometrium that will be hypoechogenic, and there is a lot of fluid inside to the lumen of the uterus. And the lumen of the uterus appear like a star image or a Christmas tree image with a lot of specular reflection. And there is also an improvement in thickness of the vascular tonica because the port of blood is improved a lot. So attention, because as you can see, the quantity of fluid present during the last 2 days of the proestrus, during estrus, and during the first 2 days of metaestrus is quite big. And sometimes we have quantity of fluid during the estrus day that is bigger than the quantity of fluid that you have in a gestation of 32 days. This is a particularly big problem for those technicians, sonographers, who still today are doing the pregnancy test only evaluating the presence of fluid inside to the uterus. This is one of the cases that you define like pregnant, but it is not pregnant. When you do a pregnancy check, you have always to check the ovaries and the fluid, but above all the embryo. Attention, because also sometimes we have pathologies, inflammation of the uterus that we will discuss in the next future meeting, like a mucometra, where you have a persistent CL, you have fluid inside to the uterus. Sometimes this fluid is perfectly anechoic, but there is any embryo. So also this is another case that you can confound for pregnancy if you don't check the pregnancy in function of the presence of the embryo. Well, here is a proestrus at day 20. You see that in this case is a codominant cause, so we have 2 core cavitary CL, and one of them is with more than 1 cavity. Well, you see that in this case the number of the dominant follicle is double, so we have 2 CL is a codominant cause, so we have 2 dominant follicle of the first follicular waves and 2 dominant follicle of the last follicular waves. Well, you see that the uterus, there is a echogenic myometrium contracted, hypoechogenic endometrium dilated, is thicker, there are a lot of specular reflection, star image of Christmas tree image of the uterus lumen. So when you see this, it's impossible to mistake. And in particular, if you do a pregnancy check in early stage, around day 25, 26, 27, you can recognize immediately if you are in a progesterone profile or estrogenic profile. And if you are in estrogenic profile, well, this means that the cow is for sure open. Well, you see that during the estrus, there is transversal section, the typically star image. You see the specular reflection. You see the uterus, the characteristics of the uterus. So externally, we have a contracted echogenic myometrium, white, and internally, a thicker endometrium with a lot of black points that are the blood vessels that are improved inside. And here is the Christmas tree image. So you see that it's very easy to distinguish the uterus in function of a steroid hormonal profile that may be estrogenic during the follicular phase or progestinic during the luteal phase. Other section, in this case longitudinally section, you see that very close to the estrus moment, you see that the difference in thickness between myometrium contracted and endometrium thicker is very high. Sometimes we have a rapport myometrium, endometrium 1 to 2, 1 to 3, until 1 to 4. The other characteristics are the presence of a lot of specular reflection that are typically of the presence of a lot of fluid, but without debris, so a clean fluid inside to the uterus. And here is a movie of a cow. In this case, probably is a free follicular waves cows. In fact, it's the day of the estrus. You see that there are many dominant follicles, more than 2, and there was still a big CL. Well, this is typical of free follicular waves cows. And you see that the quantity of fluid inside the uterus is typically of a cow's pregnant of 32, 33 days. The difference are characteristics, the stratigraphy of the myometrium, endometrium, the different echogenicity, and the presence of specular reflection, the shape of the lumen. Well, doing a summary, how change the uterus during the estrus cycle? Well, during the estrus and every time that we have higher level of estrogens, so during the follicular phase, proestrus and estrus, improve the estrogen, so improve the contraction of the myometrium, improve the ecodensity, so became more reflect much more the ultrasound waves, so will appear echogenic white on the screen, while improved vascular tonica, so the apport of blood on the uterus improve a lot, so the endometrium became thicker, and the shape of the lumen became like a star image or Christmas tree, and appears a lot of artifact called specular reflection. During the luteal phase, metaestrus and diestrus decrease the estrogen's level and improve the progesterone level. This means that the myometrium stopped to become contracted, improve his thickness, became less echogenic, so reflect less the ultrasound and in part absorb ultrasound, and so we became more gray. And the endometrium reduced the thickness, so became less thicker, and in part absorb, in part reflect the ultrasound, so became more gray. So what happens that during the luteal phase, myometrium and endometrium, they became very similar for thickness and for echogenicity. Well, here in this table, I did a summary of what happens for myometrium and endometrium thickness, and myometrium and endometrium echogenicity, but also I show what happens inside for the vascular tonica during estrus, metaestrus, diestrus, and proestrus. And I hope that can help you to understand a little bit better what is happening during the different steps of the estrus cycle in the uterus. Well, now we start officially our ultrasound evaluation of the pathology of the uterus. Well, for the definition of the uterus pathology, we are still using the terminology proposed in 2006 by Martin Sheldon, Gregory Lewis, Stefan LeBlanc, and Robert Gilbert. So we speak of metritis to define acute inflammation of the uterus during the first 21 days in milk. And after this time, we start to speak of endometritis to define chronic inflammation of the uterus. Well, the classification is more complex. You see that the metritis can be divided in puerperal metritis, typically of the first week, postpartum, sometimes when the colibacteria enter in the blood vessel, produces septicemia, we have a septical metritis. And then we have the clinical metritis that is typically of the second weeks postpartum. After 21 days, we start to speak of chronic inflammation of the uterus, endometritis. The endometritis can be divided in clinical and subclinical endometritis. The difference is that in clinical endometritis, we have vaginal discharge, while in subclinical endometritis, no. Well, the clinical endometritis may be divided in purulent and mucopurulent endometritis. The difference is that purulent endometritis are typically of day 21, 26, 27. We have more than 50% of neutrophilus, while the mucopurulent endometritis is over 26, 28 days, and we have less than 50% of neutrophilus. Well, subclinical endometritis, well, when we speak of subclinical endometritis, probably we have also to include mucometry and pyometry between subclinical endometritis, because it's extremely rare that this chronic inflammation of the uterus have an open cervix, so we have vaginal discharge. Well, relatively recently, we started also to include between the uterus pathology the purulent vaginal discharge. Well, the purulent vaginal discharge is not only one pathology, but include different pathologies who produce vaginal discharge. So include endometritis, but attention, not always the presence of purulent vaginal discharge may be produced by an endometritis. So maybe that sometimes is produced by an inflammation of the cervix or an inflammation of the vagina, or sometimes an inflammation of the kidney or the bladder. Well, attention, because we have seen that it may be possible to find purulent vaginal discharge in absence of endometritis, but maybe also that we have endometritis, so clinical endometritis, without vaginal discharge. Inside the uterus, we have also other pathologies that we will discuss in the future meeting. I want to remember the main, it's important. So, uterus abscess, the uterus cyst, the neoplasia of the uterus, fallopian tube disease, but we will see also pathology of the vagina and pathology of the cervix in the future meetings. Well, where we can start to use an ultrasound. Personally, well, I start to use my ultrasound unit only after day 10, 12, 13, after the calving, after the delivery. I'm not able to find an application of the ultrasound for the diagnosis of retained placenta, but also for the diagnosis of puerperal metritis. Well, I work with my ultrasound for the definition of clinical metritis, but not for puerperal metritis. So honestly, but it's my fault. I am not able to applicate, to find the strategy to applicate my ultrasound for the diagnosis of the puerperal metritis. For this type of diagnosis, I believe that we can use other methods that are simple and probably with a better cost benefit. So there are some people who are using hand in vagina, Metrichek score, Speculum, Metrichek, rectal palpation. Well, I like to use Metrichek score, but not to do individual diagnosis, but when I am working on the postpartum pen, to take pictures of the situation inside this pen. How many cows of the first 10 days postpartum have dirty vaginal discharge? So in function of the typology, of the quantity, if it's fluid or more dense, of the smell, I can take pictures of the situation. Some people like to use hand in vagina. About hand in vagina, well, I am a little bit critical. I believe that it's possible to do this type of diagnosis of puerperal metritis without to put my hand in vagina. In particular, it is dangerous for those cows who has, for example, vaginal laceration. Some people like to use rectal palpation, but we have to remember that with rectal palpation, in 40–45%, it is not possible to produce vaginal discharge. And attention, some people are checking the tonicity of the uterus, telling that if there is a metritis, there is no contraction of the myometrium. It isn't true. Also in puerperal metritis, we have sometimes a contraction of the myometrium. Other people like to use the Metrichek. The Metrichek is useful if you don't like to work with an ultrasound unit, for example, for the diagnosis of endometritis. But some people are also using for the diagnosis of metritis. I believe that we have the same problem that the hand in vagina is a little bit traumatic. Personally, I don't like to use it, in particular because I have to sterilize between each cow, so this creates some problem. Are the same problem that we have with the speculum. We can use different speculum, different typology of speculum, but the quality of the diagnosis is fantastic. If you want to do individual diagnosis of sick cows, very, very well. But if you want to do a screening of a group of cows, well, this is not a good method. Why? Because you have to sterilize the equipment each time, and this requires a lot of time. In the recent year, there's been also developed another method that is the Vaginoscopy. Is a very good method. I repeat what I told for the speculum. This technique is fantastic. You can see perfectly. You can analyze the situation very, very well. The problem is that also working with a sanitary bag, you have also to pay attention to sterilize very, very well the equipment between one exam and another exam. Well, at the end, why I don't believe that ultrasonography helps us too much for the diagnosis of puerperal metritis? for one reason, because now you are looking at perimetritis, but if I compare a cow at day 6-7 with perimetritis with a cow that is without, there is any difference ultrasonographically. So why? Because 100% of the uterus after calving have a contamination of bacteria, 100% have an inflammation. So what I can see is that there is an inflammation, and so there is no pathognomonic signal, ultrasound pathognomonic signal, who permit me to distinguish between a cow sick for perimetritis and a cow without a perimetritis. Well, what I can do is, with my ultrasound, is the diagnosis of perimetritis. The perimetritis is a pathology that happens when in those farms where is used the message of the uterus. I'm not against the message of the uterus, but I'm against this technique if it's not well done or is done from people without experience. When you are doing very, very bad these techniques, these are the results. So you have a perimetritis that sometimes is dangerous for the life of the cows, and in the best condition, when the cows survive, we have adherents who don't permit them to spread these cows for the reproduction, because the uterus is connected with the abdominal wall, ventrally, laterally with the rumen, or sometimes with other abdominal organs. Well, I like to use ultrasound for the definition of the clinical metritis. So I start to work with my ultrasound in cows after day 10. Well, to do diagnosis of clinical metritis is easy. It's possible to do it also only looking the cows. Normally, the clinical metritis is characterized from the presence of vaginal discharge, white or pink, and are very dense. And the cows, the major part of the cases, it is without fever, and also the vaginal discharge are not putrid. Well, also in this case, I believe that is interesting in ultrasound evaluation to see, first of all, if the uterus involution is faster or not, and also to see if the level of involution of the cotyledons is regular, to see if the quantity of fluid and the typology of the fluid inside is regular. So if we have fluid that is a continent that is very fluid, this is a bad signal, while if the continent is very dense, this means that the uterus involution is working very well. I use also this type of exam, ultrasound exam, also to evaluate the presence of corpus luteum. In regular cows, normally between day 7th, 8th, after the delivery, we have the first recruitment, and normally we have the first ovulation in 99% of the cases without estrus signal around day 13, 15, because there is the ovulation of the dominant follicle of the first follicular waves. Well, another interesting thing is that often checking the cows at this moment, over the cotyledons, we can find an hyperechoic stripe. And well, this is normal, is the epithelium that is in necrosis. And you have to remember that the uterus involution, macroscopic uterine involution of the uterus require between 4 and 5 weeks, but the microscopic involution, so the regeneration of the epithelium of the endometrium, require between 6 and 8 weeks. So during the first 10 days, 15 days, if we check the uterus, we can see a typically white line over the cotyledons. This is the epithelium that is in necrosis, and under this there is the regeneration. Here you see another cows with endometritis. In this case, you see the white debris over the cotyledons that I was telling for the necrosis of the epithelium. And you see that in this case, we can define very well the shape of the cotyledons and the continence of the uterus that is quite dense. So this is a situation that is quite good. Well, I am arrived to the end of my talk. I hope that has been interesting for you, and I see you to the next time. I hope very early.
Thank you very much for listening. Thank you, Dr. Giovanni Gnemi. It was a fantastic presentation, very clear and very thorough. Just to remind everybody, it was a pre-recorded session, and therefore we will not have live Q&A session. However, if you do have any questions or comments for us to make, please do not hesitate to get in touch with us here at IMV Imaging, either through our website or social media channels. We also have lots of educational resources for bovine specialists. They are all free and open access. Please take a look at our website. Please don't hesitate to get in touch with us. Thank you for attending our webinar, and until next time.